My talk this morning is on newer drugs and adjuvants in obstetric anesthesia. And the objective of my talk will be to describe the principles of evaluating new drugs and additives in obstetric anesthesia, and then to highlight some of the newer pharmacological agents that we are using in obstetric anesthesia. I'll start with some disclosures. I do have no financial disclosures. I have no industry affiliations, and I'm entirely supported by institutional funds. Another important thing I'd like to start with is don't try this at home. I'd like to emphasize a very important principle is that research results don't always automatically translate to clinical recommendations. And so people like me will sometimes tell you the results of studies showing certain drugs or combinations may be effective, but that doesn't automatically mean that you are free to then go ahead and use them in your clinical practice. This particularly pertains to the use of neuraxial drugs, because when we introduce drugs to the spinal cord or spinal canal, there are some very important medical, safety, ethical, legal and regulatory requirements that you have to attend to. So this is an outline of my talk. I'm going to focus on the rationale for mixing and adding drugs, and then spend some time talking about an understanding of drug interactions. This will really be, these two areas will be the main focus of my talk. And then I'll talk a little bit more about current and newer drugs and adjuvants, with an emphasis on epidural and spinal drugs. So let's start with considering epidural drugs. And I think there's no question that the gold standard drugs for epidural anesthesia, analgesia in obstetrics, are the long-acting local anesthetics. I'm sure you're familiar with bupivacaine, ropivacaine, and levobupivacaine, marketed in slightly different amounts in different countries. And there's no question that these long-acting local anesthetics are very effective on their own for labor analgesia. And so there are very many people who believe in the power of one. And you can get very effective analgesia simply by using a local anesthetic on its own. But more and more around the world, I think practice is changing. And certainly in my hospital, we almost invariably will add more than one drug together, although local anesthetics on their own are effective. So why do we do this? Why do we mix drugs? What is the rationale for mixing and adding drugs? And of course, there must be some possible advantages. And the main advantages, I would say, would be firstly, an attempt to decrease the side effects of our drugs. And secondly, to try and increase the efficacy. And these are very important advantages. But it's also important to consider that there are also possible disadvantages. You must always bear this in mind. And these include the fact that there may be a possibility of drug error. Particularly with epidural and spinal drugs, there's a possibility of a breach of your sterility. Some drugs are not compatible with other drugs. Many of the newer drugs, of course, are very expensive. And there's also, as I mentioned before, safety considerations. And you must appreciate that many of the drugs that we use epidurally and spinally, particularly the newer ones, are often given what we call off-label or outside the manufacturer's recommendations. And a classic example of that, certainly in my part of the world, is fentanyl. Fentanyl is not approved for epidural or intrathecal use, but we use it all the time. So you have to bear that in mind. So let's address some of the possible advantages of mixing and adding drugs. The first one is to decrease side effects. And to explain this, I'd like you to imagine a hypothetical situation when we give a parenteral opioid to a patient to try and reduce pain scores to a certain threshold. So it could be, for example, morphine. And you can imagine that a dose of this drug might be 10 units to get your pain score down to 2 or 3 or some particular threshold. But very often you know that this threshold will be above the limit that will cause a side effect such as nausea, for example. And so a very common practice when we give drugs such as opioids is to add a secondary drug, such as a non-steroidal anti-inflammatory. And the rationale behind this is so we can reduce our dose of opioid below the threshold that causes a side effect such as nausea. And this is a very common practice in what is called multimodal analgesia. Of course, we are concerned about nausea when we give local anesthetics for analgesia, but some of the more important, perhaps, side effects are those of motor block and hypotension and toxicity. So if you extend my model to the use of local anesthetics, you can imagine you could give a dose of 10 units of a local anesthetic to get a certain pain score. But if you add a drug such as an opioid, you can reduce, for example, a side effect such as motor block below that threshold. So this is a very important way of thinking of why we mix drugs together in epidural anesthesia. Does it have any effect? Is there any clinical effect? Well, yes, there is some evidence. And one very important study that I would highlight now is this paper from The Lancet, 10 years ago now, the effect of low-dose mobile versus traditional epidural techniques on mode of delivery from the UK, otherwise known as a COMET study. And the COMET study was a large study. It looked at over 1,000 nulliparous labouring women. And the investigators divided patients into 3 groups. The first group here in blue received what they called a traditional epidural with what now is regarded as a fairly high concentration of bupivacaine, 0.25%. And then there were 2 other groups, which are lumped together in red, who received a lower concentration, 0.1% bupivacaine, to which was added a concentration of fentanyl at 2 mics per mil. And these 2 low-dose groups received CSE or an epidural infusion, but I'll lump them together as one group here for my presentation. And what they did was to compare between the blue and the red the obstetric outcome. And the results were very interesting. This is the main result that's of interest here. On the vertical axis here, you can see this is the percentage of normal vaginal deliveries. And you can see that there's a modest yet significant difference between the low-dose group here and the traditional group here. So it shows fairly clearly that if you use a low concentration of local anesthetic, which you can achieve by the addition of an opioid, you can improve obstetric outcome by increasing the number of vaginal deliveries or decreasing the number of instrumental deliveries. So in terms of decreasing side effects, I think we can give that a tick. Yes, there is fairly clear evidence. But what about the other objective, to increase the efficacy? And in fact, this is a little more tricky to understand. I'd like to show you a hypothetical situation of a typical study. And a typical study that investigators like myself sometimes will do would, for example, to compare drug A mixed with drug B and compare that with drug A alone. A very typical study. You'll see these every day in the medical journals. And a hypothetical situation, you might compare bupivacaine, for example, 20 milligrams epidurally, and add fentanyl to it, and then compare that with just bupivacaine. And the result will show quite clearly that adding fentanyl to bupivacaine improves the analgesia. So people say we should be adding fentanyl. But the more important research question really is, if you add fentanyl, is that any better than simply giving a larger dose of bupivacaine? And this is a question that very often isn't addressed in some of these studies. So when you read these studies, look at what the comparative groups are before you automatically say, well, this is a good thing to do. Another important point is when you are adding drugs is that the neuraxial effect should always be greater than the systemic effect, because you know adding drugs neuraxially is never without some risk. And so, for example, if you're adding 50 micrograms of epidural fentanyl to bupivacaine, you must be sure that this gives you an advantage over simply giving 50 micrograms of intravenous fentanyl. I think for fentanyl there is an advantage, but for many of the drugs that are investigated, perhaps that advantage is not quite so clear as perhaps the abstract of that study might suggest. So in terms of the rationale for mixing and adding drugs, what about understanding drug interactions? This is also very important for you to understand the results of these studies. I was encouraged to perhaps spend a little bit of time on this because I read this article very recently that was published in an open access anesthesia journal that comes from here in India, from Lucknow, entitled Synergistic Effect of Intrathecal Fentanyl and Bupivacaine in Spinal Anesthesia for Caesarean Section. Synergistic effect here is what I would highlight. Now, without meaning any disrespect at all to these authors, this paper had absolutely no evidence at all of any synergism. This is a term that is often misunderstood, and I'd like to spend a little bit of time discussing this because it's very important for you to understand the results of other studies. In the main way, this may be common knowledge to some of you. If you already know this, you can have a sleep, but for some of you, perhaps it's a little more novel. To understand drug interactions, you really have to understand the concept of an isobologram. So what I would like you to do is imagine giving a drug A, at a dose that will achieve whichever outcome you want. It might be a pain score of 2 or whatever. And with drug A, you could imagine that we require a dose X. At the same time, we could imagine a second drug. We'll call this drug B. And drug B will give you exactly the same effect, the same response, at dose Y. You can imagine that we could add various combinations of A and B together at any different ratio, and these could be represented by all these grey dots, any combination, 2 milligrams, 10 milligrams, 1 milligram, 5 milligrams, whatever. But what we're interested in is, what about additivity? This is the most common effect that you'll see, the most common interaction. And additivity describes the situation when both drugs have equal efficacy. So the easiest way to understand it is imagining drug A and drug B are the same drug, they're both morphine. So you could give half of drug A and half of drug B, and you get exactly the same effect. Right. So what you have is a situation where 0.5 plus 0.5 equals 1. That is simple additivity. In fact, you can draw a line across here, which is called the line of additivity, and any combination of drugs along this line will give you exactly the same effect. Additivity. So, for example, you could use 1/4 of A and 3/4 of B for additivity, or you could give 3/4 of A and 1/4 of B, and again get additivity. Half plus a half equals 1. That, in fact, describes the interaction of the vast, vast majority of drugs that we give. But what we're really interested in is, can we provide this holy grail, what we call synergism, or sometimes called superadditivity. This is a situation, if you could imagine, you give 1/3 of A and 1/3 of B to get the same effect. Right, and you could, again, draw a line showing any range of drugs that will give that effect. And so you have a situation of 0.3 plus 0.3 equals 1. And this, of course, is a bargain. Right? And I know Indian people, like Chinese people, we all like to bargain. Chinese people love to bargain. So this is what we're looking for. Finally, there is a situation that will occur occasionally called infraadditivity. This is a situation where, for example, you use 0.6 of X and 0.6 of Y to get the same effect. And this indicates some degree of antagonism between the two drugs. This occasionally can happen. So how does this synergism work, this holy grail of synergism? Well, you can imagine that firstly, for additivity, this would describe the situation when you have two drugs working on the same receptor. So it could be morphine and pethidine acting on the same opioid receptor. And it's easy to understand, you get the same effect just simply by adding the two effects. And synergism probably occurs because you have two drugs that work on different sites. And so they work here in series, thereby one amplifies the effect of the second. And this is probably the main mechanism underlying synergy. So are we dreaming? Are we dreaming about the possibility that we may attain a synergy? In fact, when you look at epidural anesthesia and analgesia and obstetrics, there are very few papers indeed that show that spinal or epidural drugs are synergistic. Most of them show additivity. We do have some work from my centre, this is unpublished data, where we've looked at combinations of intrathecal fentanyl and bupivacaine, showing, this is an isobologram here, there is some evidence of synergism. Although I'm not showing you the confidence intervals, this work has not been peer reviewed, this is the first time it's been presented, so I can't say to you that this work is definitive. But there is, I think, some evidence. So in terms of possible advantages, I think for local anaesthetics and opioids, I firmly believe that the advantages are fairly well proven enough for me to recommend it in terms of efficacy and side effects. However, when we consider local anaesthetics and other drugs, I don't think in general that these advantages are clearly proven. What are the usual suspects? What are the drugs that people have been adding together? Well, the main ones I'll focus on very briefly because of time will be epinephrine or adrenaline and clonidine, neostigmine and some others. Epinephrine and clonidine are interesting drugs. They have different structures, but they have a high degree of crossover with certain of their pharmacological effects, and particularly the fact that they both cause presynaptic stimulation of alpha-2 receptors. The stimulation has an effect on noradrenergic inhibitory pathways and the pain pathways. Also, there may be some effect by cholinergic activation, an effect on conduction block, and also perhaps some effect by local vasoconstriction. So this is the underlying mechanism by which these enhance analgesia. Typical doses for clonidine epidurally are about 60 to 75 micrograms if you look at the literature, or for intrathecal clonidine about 30 micrograms. There are a range of different doses that have been used, but in general these are the main doses. Is there any evidence that clonidine adds any analgesia? Well, yes, there are. There are a number of studies, and just one I would highlight comes from my friend Ruth Landau from Switzerland, currently in Washington, USA. This was a study where she looked at the dose-sparing effect of clonidine added to ropivacaine for labor epidural analgesia. And she showed fairly clearly, I haven't time to show you all the data, that there was decreased local anesthetic requirements and decreased motor block by adding clonidine. But are there any problems? Are there any problems with adding clonidine and epinephrine to local anesthetics? Well, yes, there are. Particularly with epinephrine, right, it's been shown quite clearly that adding adrenaline to your local anesthetic does increase the incidence of nausea and, more importantly, of motor block, which is one of the main things we're trying to avoid. So I don't think that epinephrine really currently is a drug where the side effects and advantages are in an appropriate balance. Clonidine has more potential, I believe, but particularly in larger doses it may be associated with these side effects: nausea, sedation, hypotension. Importantly, I think particularly for this part of the world, cost is a very important issue, and also there's some questions when used at higher doses that it may have some potential effect on fetal heart rate patterns. And so there are some question marks over clonidine. And I did notice on our program tomorrow there's a sort of a pro-con debate on clonidine. So perhaps I would encourage you to go there. I will go myself because I think that there will be some interesting debates and I'm keen to learn more on clonidine. Neostigmine is a drug I think that has more potential than clonidine for epidural analgesia. Neostigmine is a drug that we all know. We're all familiar with it, and importantly, it's a very cheap drug. Right? So it's a drug that we all have available in our drug cupboards. Of course, neostigmine, as you know, works by cholinesterase inhibition. Right? This increases acetylcholine concentrations, which stimulates nicotinic and muscarinic receptors in the spinal cord. And this has an interaction, an anti-nociceptive interaction with several pathways, including opioid, noradrenergic, as well as adenosinergic pathways to facilitate or enhance analgesia. It's very important, though, when you consider neostigmine, very interestingly, that epidural use seems to be very effective. But interestingly, even in small doses, neostigmine is associated with a very, very high incidence of nausea when given intrathecally. So this is a drug I think it's fairly well established clinically that it shouldn't be given intrathecally because of the side effects. But I believe this is a drug that has much potential for epidural use. Again, if you remember one of my early slides, I'm not saying that you should go back to your units and use it, but I think this is one that we should be at least keeping our eyes on. Epidural neostigmine has been investigated in doses roughly in the range of 500 to 700 micrograms combined with a local anesthetic, opioid or clonidine. And it's very interesting that there are some studies showing that neostigmine and an opioid alone can provide good analgesia, so no local anesthetic at all. What about other drugs? Well, some of the other drugs that have been investigated include ketamine, tramadol, midazolam. Problems with ketamine and tramadol is that studies aren't convincing that the neuraxial effects are greater than their systemic effects. Some have, some haven't. And with midazolam, there are some question marks over its neuraxial safety. So again, these are slightly experimental drugs in my opinion. Finally, I'll very quickly touch on newer intravenous drugs. So two of the drugs that I think are exciting for us are remifentanil and dexmedetomidine. I'm not entirely sure about the availability of these drugs here in India. Remifentanil is a drug that, for example, my unit, many units around the world are embracing for labor analgesia given intravenously. Because as you know, it has a very good pharmacokinetic profile in the context of obstetric analgesia, particularly its very short context-sensitive half-life. It has a rapid onset, short duration, which means that it's very titratable. Right? But there are some very important questions regarding its efficacy compared with its side effects. And certainly our experience giving it to patients whom an epidural was contraindicated or refused is that you can get very good analgesia, but almost invariably your patient will have sedation and desaturation. So this is a drug that, again, I don't think should be used in a situation unless you are confident in the degree of your monitoring and your supervision. So use with care is probably the most important line on this slide. Dexmedetomidine is a newer drug that I think has great potential. This is a drug that our intensive care colleagues use very routinely for sedation. I was very interested to see this study that again comes from India, one of the only drugs that looked at clonidine and dexmedetomidine used together epidurally. But there are very few data looking at dexmedetomidine epidurally. Where I think perhaps it has particular potential, particularly in many of us come from units where patients don't like to have epidurals, is the potential for intravenous use. And this is just a case report, but very interesting, that comes from, we all know, the Brigham Hospital. We have great representation from this very important hospital here today. This is a case report accompanied by an editorial by Alex Sear from my association. And in the interest of time, I'll just refer you to this. Again, not a drug we should be using routinely, but a drug to keep an eye on. So in summary, ladies and gentlemen and friends, adding drugs in epidural anesthesia is useful, but please do ensure that there are clear advantages before you adopt it widespread in your practice. It's important that when you contemplate adding drugs, that you look for clear evidence of reduced side effects, additivity, and if possible, synergy. I believe that local anesthetics with a lipophilic opioid is the standard that we should be using at the moment. Clonidine and neostigmine have potential, but I believe that the jury is still out as to whether or not these should be our routine drugs. And so I would encourage you to watch the journals, and particularly the editorials that will give you some idea or a summary of what position these additives should have in our daily practice. And I'd like to thank you very much for your attention.